Thank you for joining us for today's RISE webinar. This webinar is the second in the series and is on population health management, a core concept of the Ontario Health Team Model. My name is Rob Reid. I'm the Chief Scientist of the Institute for Better Health at Trillium Health Partners in Mississauga, and I'm one of the co-leads of the RISE platform. We have many people registered for today's webinar, and I would just wanted to remind everybody about 4 more webinars coming up here to topics relevant to the Ontario Health Team. The next important one is next Monday, where we will be discussing how OHTs can approach their work with their attributed population. And for colleagues who can't make it today or want to listen to this webinar again, it's available and we post it on our RISE. Now, just a little bit of background on population health management. The concept of population health management brings new perspectives and functionality into the delivery of care by OHT partners. And it demands that partners work in an integrated fashion in terms of management. Population health management asks teams to extend their focus not only on those that they currently care, but now to their entire population, and incorporate proactive as well as reactive modalities that engage people directly in the care activity. And finally, they incorporate person-oriented perspectives, not only disease-oriented ones. This is a very big topic and one of the biggest transformations that Ontario Health Team will make. And I realize that this is just a starting point on this. And I also realize that people are starting in very different places in their understanding of population health. For some of you, this is a very new concept, and then some of you have been working with these concepts for years. So today's webinar is really meant to anchor everybody in the key concepts, whether they're new or whether they're a review. And I'm not going to be going into any depth. We'll delve much more deeply into these concepts in the coming years. Each of your priority populations that the OHT are selecting will require really specific management strategies, and that will have to be defined. But I'm going to talk more in generality. This is really to get you thinking about your approach and how they can be refined and improved for each of your priority populations. And most of what you're going to hear from me today are my perspectives and my experience working as a medical leader in the area of population health management for many years in a large, high-performing U.S. healthcare system. Was Group Health Cooperative, is now Kaiser Permanente. And I just want to remind you to use the question box, ask questions, and we'll come back to those later. So here's the plan for the next 50 minutes or so. I'm going to review some of the key concepts. And I just want to remind people that these concepts are slippery, and it's important to revisit this theme regularly as you're writing the OHT applications and as you're implementing OHT. All teams invited for full application, you should have now received your data package on your attributed population that describes their size, where patients come from, the health status, and their use and cost patterns. And as you think about delivering care in different ways to the attributed population and to the priority population you select, this webinar will specifically talk about introducing new proactive aspects of care that are embedded in the concept of population. Because the concepts are slippery, I'm also going to talk through a real-life example that I know, and it's managing a population of patients with hypertension. And I realize that you'll be selecting other priority populations, but the selection of this example is really to reflect the core concept. After I talk, we'll have Tyler talk, VP Strategy Consultant, and Carolyn Goff, VP of the State Business Health System, talk about their perspective on how they are approaching population health. At the end, we'll respond to some of your questions, and I'll ask Harry to catalog these and use them back for us. So let's start with a definition. We should all be proud as Canadians that we were actually leaders in the introduction of the concept of population health around the world. And many of you on the call may remember the Lalonde report that emphasized the non-medical determinants of health and making sure that we actually manage that at a population level. This is a generally accepted definition. Comes from Greg Stoddard, who's at McMaster, and his colleague Dave King from Wisconsin. And population health is defined as the health outcomes for a group of patients. It's not only about the processes of care, it's actually about the outcomes of care. That's important. And second is it's about evening out the distribution of health outcomes across the population, across the whole population. In other words, it's not just about the mean, it's around the distribution of those outcomes around the mean. So inherently in the concept of population health embeds the notion of health equity of outcomes across a population. And so when we look at the performance indicators, and many of you have them now in your, that have been distributed in your data package, it's easy to concentrate just on the mean or the percentage of people that are achieving a particular outcome, but it's also important to look at the distribution around the outcome and seeing if it is applying to all of the subsets of population. So I encourage you to look at the distribution and look for an equity. You don't see inequities unless you look for them often. Geographic, right, ethnicity, by socioeconomic status and the like, and to develop strategies to reduce inequity in the delivery of care. This is actually what population health is also. So let's delve a little bit more deeply into the concept. How does healthcare and integrated delivery systems like those envisioned by Ontario Health Team actually produce health in population? For OHTs, everybody right now is currently challenged to choose a priority population within the attributed population where they can have early and maximal impact, improving health, bringing in spending, and improving experience for families, caregivers, and providers. There are many ways to think around how health systems actually produce health across the entire population. So I find this article that I've shown here particularly helpful in clarifying and organizing my thinking. And I encourage you to read it by Eugene Washington and Tim Evans in the journal, American Medical Association. And it talks about the role of healthcare in shifting the three curves of population health that are all quite different in terms of how they produce health. And it talks about specific actions that can be taken to shift each of these three curves so that we move the overall population from one that's less healthy to one that's more healthy and one that narrows those gaps that I was talking about in the distribution. So let's talk a couple minutes on each of these three curves, and then I want to focus on the middle, the population health management. So the first curve, the black one, is one that virtually everybody on the webinar today is familiar with. And it's about how our system responds to new health concerns when they arise. Stroke, myocardial infarction, trauma, depression, cancer, and even simple urinary tract infections. The focus is on providing accessible, high-quality services around the three episodes of care, be it their visits, be it their be it their hospitalization. The focus is on individuals. The focus is not on population. But population health is produced, and it comes by applying these services one by one. Okay? So OHTs will absolutely continue to need to provide this reactive services of care and be able to manage high quality care when patients are really needing these services, providing high caliber care for stroke, myocardial infarction, cancer, infection, and the like. This is still a vital part of population health, but I'm not going to emphasize this curve anymore because this curve, everybody on the call here knows this curve. The second curve, though, is one that I really want to spend some time talking about, and this is the population health management curve, the yellow curve on the diagram. And it's concentrated on managing chronic or recurrent health issues and on managing behavioral risk factors. And rather than taking an episode of care, population health management is a longitudinal perspective. It focuses across efforts. And it actually, in fact, often has no end because these are chronic concerns that go over years. The focus is on long-term management and on engaging people across the spectrum in effective self-management. And the focus is on the population, applying health services proactively in addition to the reactive nature that I talked about, and reaching all individuals across the population, not just the ones that are seeking care, but proactively reaching out to manage those long-term behavioral risk of and remembering Stoddard's and King's definition, population health management extends to equity and removes the barriers of care to the people that when they exist. So this curve is really around applying good clinical care for ongoing health issues proactively across the population and engaging patients directly in self-management care. This is the population health. Lastly, I want to just talk briefly around this third curve. This is what is meant by the population-based curve, population-based strategies and interventions. Some people talk about this as the population health improvement curve. And this is also where significant work is done by the OHTs. The emphasis is on fundamentally addressing the non-medical determinants of health at the population level. And it's not actually on healthcare. It's not on organizing effective care. It is actually working upstream and fundamentally delivering population health strategies around those non-determinants of health, be it their housing, income, transportation, and security. And this graphic that I got from the Canadian Medical Association really shows that healthcare only contributes a minority of health in the population, and that these factors contribute a minority. The focus is at population-based level, designing income assistance programs, transportation initiatives, housing and support, financial support, and community support systems for populations to try to narrow out those health inequities that come from social and economic. And in healthcare, and OHTs and healthcare institutions can have important roles to play here. And we can't neglect either in healthcare delivery, to facilitate, and actually to advocate for these types of strategies. We're going to be talking about the population, this curve, the third curve, the population-based strategies and interventions in another webinar. The focus of this webinar is really on that second curve, the population health management. So now I'm going to move away from the concept of definition Hopefully I've lessened the fog a little bit that many have told me are out there because these are confusing concepts. Now let's talk a little bit about population health management strategies in that second part. Proactively reaching out to manage chronic health concerns, organizing care, and behavioral risks around the population. Your attributed populations are big, and many of them are very large. They have very different types of people within those populations that have very different population health management needs. And the first step in managing population health in a full population, in a attributed population, is to segment the population into groups of patients with similar needs, so that you can design appropriate, proactive strategies to manage these groups. That's the rationale behind selecting the priority population. And this triangle reflects the whole diagram, reflects the entirety of the population that can be defined into three general, all with different types of population. At maturity, Ontario Health Teams will need population health management strategies in each of these segments. But right now, we're focused right on the priority populations that will fit into one of these three segments. But this will evolve, and you will need to develop strategies across the full population. The black segment, or the gray segment in this diagram, is the low risk group, and it's the largest. We focus the general, the healthiest. And here the population health management strategies are used to proactively address risky behaviors, chronic diseases, such as tobacco use, risky drinking, overweight and obesity, chemical dependence. And preventing using screening and other prevention techniques, and actually applying well-managed and helping well-managed chronic illness, such as early arthritis. The yellow segment is a focus that many of our priority populations are, and this is the emerging risk group. Really, this is the group with greater burden of chronic illness, diabetes, depression, cardiovascular disease, occurring singly or more often in combination. And these combinations need to be proactive. And we also need to manage the behavioral risk factors that I mentioned earlier. One of my colleagues many years ago said the most important component of population health management for patients with diabetes is actually tobacco use. And it's stuck with me forever. Forever remember that it's not only managing the condition, but it's actually managing. And then the blue group at the top here is the complex patients. They're characterized by multiple morbidities, disabilities, frailty, and maybe even the teams across the OHTs are selecting different populations in this chart. But again, OHTs are expected to have population management strategies at maturity that cross these communities. So, but regardless of the priority population approach that you choose, population health management encompasses three main elements that need to be simultaneously designed. The first is around clinical decision support. And this is really around getting everybody on the team on the same page around how we're managing this particular similar needs. So this is about having common clinical practice guidelines. What interventions will we deploy? What care pathways are we deploy? How we'll deploy them? It's about identifying and removing barriers in that care pathway. And it's also often about sharing those care pathways with patients and families directly so that there's transparency about how patients. In addition to the care pathways and the clinical practice guidelines, it's also about having automated prompts and reminders to remind patients and providers to follow those care pathways. The second component is really the clinical information. And this is really around putting in place the support to provide clinical, the information support to provide clinical population. This is about registry, around knowing who is in your subpopulation, trackers that track service delivery and track outcomes and barriers to care so that they can be removed, brought in. And these are about the clinical information systems you can stretch across service providers. And the good thing is these days is the robust EMRs in place in hospitals and ambulatory centers often have these functionalities built into them. So they have population-based population management information systems built into our EMRs. The third component is really around system leaders. It's about knowing who's on the team and what they do. And it's having new roles and functionality to make sure that the population health management in-reach and outreach that we're talking about in those care pathways are actually actualized. They're about new methods of delivering care, virtual care, telephone care, self-care. It really is about building out our toolbox around service delivery options to fulfill the population. And it's also about the importance of building mechanisms in care navigation, care coordination, and care management into the pathway. So that's where the redesign actually is. And then finally, and I couldn't stress this enough, it's actually building in patient and population self-management support mechanisms. It's about building and supporting patients around motivation, skills, capabilities for behavior change, and providing systematic support. So if you remember these four components of moving from reactive to proactive care, the concept of population health, these will apply to all of the different parts of the population. And those familiar with population health management on this call today will see that the elements that I just talked about actually are embedded in Ed Wagner's chronic care model, sometimes called the planned care model, or the population care model that was developed in the 1990s. And there's a lot of tried and true evidence around this model, and it brings together all of the components of the population. So I encourage you to use the chronic care model, sometimes called the planned care model, in your thinking. This picture is actually an example of the expanded care model. So all this is taking Ed Wagner's model and putting it into a community context. It was done by our colleagues in British Columbia, and it enhances its linkage with into the community. And I encourage you to consider using this expanded chronic care model in your. So let's focus a little bit more around the design component about designing strategies for your priority population. How do you approach it? We talked a little bit about the importance of having practice guidelines, using the best available evidence, the importance of having care pathways that bridge across the department. So how do you approach developing these pathways? There are many ways of doing it, but one is to actually look at the best. The first thing is to look at what your current state of affairs are. Where are the gaps that patients need across the pathways that need to be filled? And where are your largest care coordination needs for your priority population? that will be focused on developing the pathways that the where your current gaps are. Because of the emphasis on patient engagement, it's important that patients and families be involved in developing their pathways so they work with them and they address the areas that they have. And every population is slightly different in terms of the areas. And when thinking about the services along with care pathways and how they're delivered, think about how they deliver them in a more proactive approach. Think about applying services proactively in reach, meaning that when patients come in for a variety of reasons with reactive concerns, can we actually make sure that their planned care or population health needs are actually addressed, chronic needs are addressed? So if a patient shows up to the primary care site that is actually for ankle injury or some other thing, and yet they're on a registry for a priority population, can we do in-reach at the same time to address their chronic illness and chronic behavioral? And then secondly, it's about outreach. And this is proactively reaching out to people on your registry and so forth who have care needs and then bringing back in. But of course, population health management necessitates that we're tracking, reporting, and reminding people to facilitate this ongoing care. We'll be talking about tracking, reporting, and reminding systems, registries, and the like in future webinars and learning events. But it's a good thing to know that there are information technologies that are absolutely up to fast to do these things, particularly embedded in many of the high schools. So now that I've talked in generalities, I wanted to give you an example, population health, an example that I know well, and it's about managing hypertension, which is a condition not low risk bucket, and it's using a population. So this example comes from Kaiser Permanente, and they selected hypertension for focus because they know that because of this the ration navigation. So improving care blood pressure control for patients is important because it's common, it's a leading medium for moving from downstream costs. The hypertension is treatable with step therapy plus patient engagement. We know that it occurs alone as well as with other morbidities, the risk factors for many conditions. Blood pressure control can reduce outcomes, poor outcomes, such as stroke and mortality. And most effective, most importantly, is there are lots of gaps. The poor blood pressure control is very common in the population. Less than half of the patients with Kaiser Permanente actually blood pressure was wrong. So what did they do? And the reason I chose this example as well is because it's written up very well in the literature, and I'm giving the citations at the bottom here. I encourage you to read about it. But it really exemplifies the design elements that were incorporated to manage health and so Kaiser Permanente actually decided on a variety of clinical decision supports that were needed. So they implemented a system-based chronic clinical practice guideline that used simple, easy to use step therapy algorithms around what interventions we needed at what. And that this algorithm is integrated into all clinical pathways. So for patients with diabetes, patients with depression, patients with only hypertension, this step algorithm is incorporated into all of those pathways. So real population-based approach on this as well. Second, is that they actually had clinical information. It took some time to design the clinical information to support population health management. So they created a hypertension registry. They were able to track who had hypertension, and actually they used standardized blood pressure measures to make sure that we knew what blood pressure control was like with patients along their journey. They had access to individual and aggregate levels of blood pressure used in clinical practice guidelines. A blood pressure level in clinical practice guidelines, so they could report that to teams about whether people were getting the care that was actually called out for in the clinical practice guidelines, so that they could actually put improvement in that. And they use treat to target thoughts and reminders and regular performance feedback back to their team. So they use their health information designed in this way that to support the population health. They redesigned the system to support population health. So they created new roles for non-physician providers, medical systems, in terms of providing, for instance, self-management support. Nurses, pharmacists took on new roles around how to manage population, blood pressure population. And they deployed systematic use of telephone reminders, e-visits, and mail reminders, new modalities to deliver care rather than just the simple population. And then finally, they delivered self-management support in new ways. And they had initiatives in place to build literacy and improvements in medication adherence, because that was one of the problems that they found with population with blood pressure control. One-on-one teaching, peer group sessions, and a whole variety of different approaches to delivering that message. So a fairly significant effort that really focused around the 4 features that I talked about before. And then this was the result. In a fairly short period of time, Kaiser Permanente, which is the one in Northern California, was able to show an improvement in hypertension control from 44% to 90% over a 13-year period. So doubling, and almost everybody was actually achieving blood pressure control, and this was using standardized blood pressure measures. But in addition to that as an early outcome of blood pressure control, they were able to show that there was a fairly quick reduction in the heart attack and actually stroke mortality in that population. So with this population self-management approach actually was able to show reductions in population health level that were substantial for that population. I didn't show you the data here, but you could actually show that they were able to narrow the gap and the distribution of the So this is just a terrific example to show how organized systems of care to deploy interventions that we know work for blood pressure can be deployed at a population level and actually achieve substantial population health outcomes in the short term. Okay. Lastly, I just wanted to focus a little bit on some guiding principles as you're thinking through these strategies that you can deploy in your own. First is, really making sure that we have patients involved in co-design processes. Patient engagement and self-management support is so critical in the population health management that really need the design to be part of the design process. We need to draw on all relevant resources from participating OHTs to think about things in different ways. There's different partners that can provide self-management support or clinical support or help with articulation with we have to be open to new roles and different roles around the getting away from some of the structures in the past that people fall through the cracks. We need to figure out where some of the barriers are to things like sharing health information across our team to make sure that we can actually deploy these populations. We actually have to find out what's working well already and leverage the OHT expertise to design these care many have been involved in things like the development care for bundled care experiments where pathways have been developed in care and bringing those into your deployment. And then really making sure that we have data and evidence to support it, and focus on improvement. These, I think, helpful guiding principles that we developed by one of the OHTs can help to assist them the OHT essential population. Okay, I'm going to